Welcome everyone to the last pre-class PowerPoint that you're going to have to listen to. And it just happens to be Neuro Part 2. So we're going to finish up with the nervous system, and we're going to focus on the parts that we haven't looked at yet. We've already talked about the brain, but we still need to talk about the spinal cord, which is the other part of the central nervous system. And then we're going to take a closer look at the peripheral nervous system. Let's start with a little review of the A&P of the spinal cord. Okay, so the spinal cord has two kinds of functions. It transmits nerve impulses back and forth between the brain and the peripheral nervous system, and it mediates spinal reflexes. Let's look at each of those functions separately. So we said the spinal cord transmits nerve impulses between the brain and the nerves in the peripheral nervous system. Now there are two kinds of nerves in the peripheral nervous system that are entering and exiting the spinal cord. There are sensory nerves and there are motor nerves. So the spinal cord is sort of like a relay station, okay? It's sending the sensory nerve impulses up to the brain, and then it's sending the motor impulses down and back out to the body. So the purpose of the spinal cord is to transmit those nerve impulses back and forth between the brain and the peripheral nerves. So basically what you have works something like this. The sensory impulse is going to come into the spinal cord on a sensory nerve, which in this picture is sort of like greenish blue. Okay, so the sensory impulse comes in and synapses with other nerves in the spinal cord. They're going to carry that impulse up to the brain, where it's going to get processed by different areas. And we'll talk a little bit more about that in a minute. But then the brain's going to process all that information, decide what needs to happen, and send out the appropriate responses back out on the motor nerves, which in this picture are red. Okay, so the motor nerves come down from the brain, go out of the spinal cord, and you're frequently going to hear people talk about two different nerves in this pathway. The first one is the upper motor neuron, which starts in the brain and goes down the spinal cord, where it's going to synapse with a lower motor neuron. Okay, so there's the lower motor neuron that it synapses with. And there you can see in the spinal cord where the upper motor neuron and the lower motor neuron actually synapse. You can see that the lower motor neuron starts in the spinal cord, but its axon extends out into the peripheral nervous system, where it's going to eventually synapse with the muscle fibers at the neuromuscular junction and cause the muscle to contract. So the spinal cord is sort of like the pathway by which the nerve impulse gets from the brain to the peripheral nerves that then innervate the target tissues. Now notice that the sensory nerve that goes into the spinal cord, there it's green, and the motor nerve that comes out of the spinal cord, pictured there as red, those are both part of the peripheral nervous system, right? They may start or end in the spinal cord, but the majority of that nerve is outside the central nervous system. So that nerve that enters and exits the spinal cord, that's actually part of the peripheral nervous system. So we said the first job of the spinal cord was to transmit nerve impulses back and forth between the brain and the peripheral nervous system. The second job of the spinal cord is to mediate spinal reflexes. And spinal reflexes are specific sets of motor responses that can be triggered without any need for input from the brain. We call them reflex arcs, and they're primarily protective in nature. Let's look at how the patellar tendon reflex works in this slide. Okay, so you have somebody hitting the person on their patellar tendon at number 1. Okay, and at number 2, you see the sensory receptor being stimulated, and now it's sending a sensory impulse up to the spinal cord on the sensory nerve that is blue in this particular picture. Okay, once the sensory nerve enters the spinal cord, it's going to synapse with a lower motor neuron, that is red, okay? And then the motor impulse travels on the lower motor neuron back to the muscle where it stimulates the muscles to contract. Okay, so you hit the person on the patellar tendon, the sensory nerve goes into the spinal cord, synapses with the lower motor neuron, that makes the muscle contract, and that's what makes the leg kind of kick out, like it happens when you test the patellar tendon reflex. Now, at the same time that the blue sensory nerve is synapsing with that red motor neuron, okay, the sensory nerve will also synapse with some other nerves that are also going to carry that message up to the brain. So eventually your brain is going to go, hey, somebody hit me in the knee, okay? But by the time the brain says, somebody hit me in the knee, the reflex has already been triggered and the person's leg has already extended. What that tells you is that reflex was not dependent on the brain, okay? You didn't need your brain in order to tell your leg, well, you should extend to protect your patellar tendon so it doesn't get overstretched. Okay, that automatically happened because of the spinal reflex, the synapsing of the sensory nerve with the lower motor neuron in the spinal cord. Did not need input from the brain. Okay, another example of a spinal reflex that's protective in nature is the withdrawal reflex. Like if you touch a hot stove, okay, the reflex is going to make your hand withdraw, pull back, kind of like till it's by your shoulder, okay? So that is a spinal reflex. You don't need your brain to say, whoa, that's hot, I should move my hand, okay? By the time your brain goes, whoa, that's hot, your hand is already back by your shoulder because the spinal reflex has caused it to pull away to get away from the potentially damaging stimulus. So that's how the spinal reflex works. Let's talk now about the structure of the spinal cord. You can think of the structure of the spinal cord in a couple of different ways. You can picture it as a bunch of longitudinal columns that travel up and down the spinal cord, carrying nerve impulses back and forth between the brain and the peripheral nervous system. Or you can think about the spinal cord as a bunch of little horizontal segments. Okay, let's take a look at each way. Okay, in this particular slide, this is conceptualizing the spinal cord as a bunch of longitudinal tracks that are traveling up and down the spinal cord. You can see, like, if you were to cut me in half and then look down on my spinal cord, okay, you would see, well, you wouldn't see the pink and the blue areas like that, but you would be able to pick out different columns or different tracks traveling up and down the spinal cord. And we actually have those tracks all mapped out, so we know where the sensory tracks are that are going up to the brain. We know where the motor tracks are that are traveling from the brain back down to the other parts of the body. And the point of the slide is to show you that the sensory tracks and the motor tracks are not all just thrown in the spinal cord, all disorganized and mixed up, but they're organized into bundles. So you have sensory nerves all traveling up the spinal cord to the brain, and motor nerves all traveling down from the brain, heading back down to the rest of the body. It's all mapped out so that we know if your spinal cord gets damaged in a certain area, this is the kind of problem that we expect to see. But remember, we can also think of the spinal cord as being a bunch of little horizontal segments that are stacked one on top of the other. And you can kind of see in this little slide that we have the little spinal cord segments labeled like C1, C2, T1, T2. So we have the different spinal cord segments having similar labels to the vertebrae that are all stacked up in your vertebral column. And when we think about the spinal cord as a bunch of little horizontal segments, and here in this picture you can also see the little horizontal segments. When we think about the spinal cord like this, it helps us to better visualize the kinds of deficits that might occur if the spinal cord gets damaged at a particular level. In this picture, you can see how we have the body mapped out into what we call dermatomes. And the dermatome indicates which part of the body is innervated by the nerves that exit the spinal cord at each level of the spinal cord, at each of the spinal cord segments. Each of those segments has spinal nerves that exit it at that level, and this dermatome map shows you which nerves and which spinal cord segments innervate which parts of the body. So again, you can see that if we know a person has been had their spinal cord damaged at a certain level, we can anticipate what kinds of deficits they're going to have. Now, there are 12 pairs of cranial nerves that exit the spinal cord, well, actually exit more at the level of the brainstem, okay? And then there are 31 pairs of spinal nerves that exit on the spinal cord itself. And these nerves, as they exit the spinal cord, they get out of the vertebral column through the little holes in between the vertebrae. So you see as the vertebrae are stacked up on top of each other, there are little holes in between two different vertebrae. And the spinal nerves, as they exit the spinal cord, will get out of the vertebral column through those little holes in between the vertebrae. Now remember we said that the spinal cord segments have names that are similar to the vertebrae, okay? C1, C2, T1, L1, that kind of thing. And you'll notice that near the top of the spinal cord, the spinal cord segments and the nerves that exit them are lined up pretty well by the vertebrae that has the same name as it. So, like the C4 spinal cord segment and the nerve that exits the C4 spinal cord segment is located at a fairly similar level as the C4 vertebrae. Okay, so it's fairly even near the top of the cord. But you notice as we move down the cord, the spinal cord segments and the vertebrae that have the same name as them don't line up quite so well. For example, if you look at these two black arrows, you notice the arrow on the right is pointing to the L1 spinal cord segment. Okay, the arrow on the left is pointing at the L1 vertebrae. Okay, so what that means is now the spinal cord segments are not lining up quite as well with the vertebrae that have the same name. What that means then is if you're talking about somebody who has a spinal cord injury, especially when you get to the lower levels of the spinal cord, it's important that you clarify, did this person have an injury at the L1 spinal cord segment, or did they have an injury at the L1 vertebrae? Okay, because the disabilities are going to be very different depending on where the injury actually is. If we talk about the L1 spinal cord segment, we know exactly where on the spinal cord the injury is. If we're talking about an L1 vertebrae injury, the spinal cord might actually be damaged more in the sacral regions, okay? And that's going to make a difference in how disabled the person is. So at the upper levels of the spinal cord, it may not be that crucial that you specify whether you're talking about an injury to the spinal cord or an injury to the vertebrae. But as you move down the spinal cord, it becomes more and more important. Now notice that the black arrow is pointing to where the spinal cord ends in this picture, okay? But notice that the vertebral canal is not empty after the spinal cord ends, right? You see a whole bunch of stuff still in the vertebral canal after the spinal cord ends. So what is all that stuff in there? Okay, well, those are the spinal nerves that have exited the spinal cord, right? They don't all exit the vertebral column at the level of the spinal cord segment where they exit. Some of those spinal nerves travel a long way in the vertebral canal before they exit through the spaces between the vertebrae. what do we call that bunch of spinal nerves that is still in the vertebral canal? Do you remember? We call it the cauda equina, or the horse's tail, because it looks like a horse's tail. Okay, that's it for the central nervous system for now. Let's talk a little bit more about the peripheral nervous system. You remember the peripheral nervous system is made up of all the nerves that you see entering and exiting the spinal cord. And basically, the function of the peripheral nervous system is to transmit nerve impulses back and forth between the central nervous system and the rest of the body. So we divide the peripheral nervous system into two parts, the somatic nervous system and the autonomic nervous system. And you remember the somatic nervous system controls the voluntary activities of your body, the ones carried out by your skeletal muscles, and the autonomic nervous system carries out the involuntary activities that are carried out by your internal organs and your blood vessels and things like that. So we'll talk more about the autonomic nervous system in a minute. Let's focus for now on the somatic nervous system. So we divide the somatic nervous system into the sensory pathways and the motor pathways. The sensory pathways are entering the spinal cord and the impulses are being carried up to the brain. And the motor pathways are exiting the spinal cord and getting carried out to the rest of the body. Now, we've already looked a little at the motor pathways, when we were talking about the spinal cord. Remember, we were talking about the upper motor neuron and the lower motor neuron, and we said that the lower motor neuron was part of the somatic nervous system. So now what I want to do is look more at the sensory part of the somatic nervous system. Now, you remember we said that the sensory nerves in the somatic nervous system carry the sensory impulses to the spinal cord, and once they get there, they can synapse with a whole bunch of other nerves. Of course, the sensory nerve will synapse with the lower motor neuron, and then you get the reflex, right? But that sensory nerve can also synapse with a whole bunch of other nerves, and those other nerves will carry that impulse up to the brain to get processed. What I want to talk about specifically is how pain impulses get up to the brain and are processed. Because I think pain is probably the biggest sensory-related problem that we have, and pain is probably the most common reason people seek health care. So let's talk about pain. Now, your book defines pain as, quote, an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Okay, from that quote, what I want you to notice is that there are two aspects to the pain experience that nurses need to address, right? There's the actual sensation of pain, and then there's the emotional response that goes along with the pain. And that emotional response is probably the thing that makes pain so difficult to deal with. Now, pain does have a useful purpose, right? Do you remember what it is? Hey, pain is sort of like the warning sign that tells you that there's a problem, and that if you don't get rid of that problem, tissue somewhere is going to get damaged. For example, when you come to class and you sit there for 2 hours listening to me talk, okay? If there was no such thing as pain, by the time you left class, you would all probably have pressure sores on your behinds, right? Because if you didn't move for the whole 2 hours, then circulation in the tissue is going to get cut off and you're going to get a pressure sore. But that doesn't happen because after you've been sitting in one position for a while, your behind starts to hurt. And so you shift your position. And so we never really get that kind of ischemia to the point where you're going to have a pressure sore. So pain helps prevent tissue damage in a lot of situations. So it's a really useful thing. That's why it's kind of unfortunate that there's still a lot of things that we don't understand about pain. What I want to talk about today is our current thoughts on how the pain process works. Now, what we think happens is that there are special pain receptors that are located in your tissues that can be activated either by mechanical stimulation, like maybe very heavy pressure, extremes in temperature, really hot or really cold, or maybe these pain receptors can be triggered by chemical mediators that are released from injured tissue. When those pain receptors are stimulated, that triggers an impulse or an action potential that then travels to the spinal cord on one of two kinds of sensory nerves. Okay, we can have the impulse travel on a large diameter myelinated A delta fiber, or it can travel on a smaller diameter unmyelinated C fiber. Now, which nerve fiber do you think is going to transmit that pain impulse faster? Probably the myelinated one, right? So the pain impulses that travel to the spinal cord on the myelinated A delta fiber are going to be interpreted as sharper kinds of pain, more localized, more acute forms of pain. Whereas the pain impulses that travel to the spinal cord on a unmyelinated C fiber are probably going to be interpreted as more diffuse types of pain, maybe more aching kind of pain, the kind that is associated with your internal organs, or that is more chronic type of pain. Once the sensory nerve that's carrying the pain impulse enters the spinal cord, it might be involved in several different kinds of circuits, or it may synapse with several different kinds of nerves. One kind of circuit pictured in the slide under number 2 is the circuit that we've already talked about, where the sensory nerve synapses with the lower motor neuron and triggers that spinal reflex that's protective in nature. That's the first kind of circuit that the sensory nerve might be involved in. Once the sensory nerve enters the spinal cord, it may also synapse with other nerves that will then carry the impulse up to the brainstem, and that's what you see in the picture number 3 in this slide. Now, once the impulse gets to the brainstem, a couple of different things can happen. First of all, the message gets carried to the reticular activating system, which is going to alert the person that there's a problem going on that needs to be addressed, or tissue is going to get damaged. Also at that level is probably where we see the autonomic nervous system being alerted, and that's going to trigger the increase in heart rate and blood pressure and all those other things that we also see occurring when a person is experiencing pain. Now, the sensory nerve probably also synapses with nerves that carry the information up to the cerebrum, which you see pictured under number 4. And in the cerebrum, a couple of other things are going to happen. That impulse makes it to the thalamus and the cerebral cortex. And now we're going to have the brain being able to interpret the information that's coming in to determine things like, what does this pain feel like? How intense is it? Where is it located? What's causing it? Okay, so we're going to have that kind of response to the pain experience. Plus, at that level, we'll also probably see the pain information going to the limbic system. And this is where we're going to get the emotional response to the pain. Now, all of that seems pretty straightforward, doesn't it? But, there are a lot of things about the pain experience that we really don't quite understand. For example, now I know we've talked about referred pain in this class before. Do you remember what it is? It's pain that we feel in a place in the body that is different from where the actual tissue damage occurred. Now, what have we talked about that is a good example of referred pain? Okay, we've talked about the pain in an MI, right? In a heart attack, where the tissue damage is actually occurring in the heart, but sometimes people experience the pain as occurring in the left shoulder or radiating down on the inside of the left arm. Okay, what causes people to feel the pain in a different area from where the tissue damage has occurred? The near as we can figure out, the reason for that is because probably sensory information from the left shoulder, the inside of the left arm, and the heart is all entering the spinal cord at the same spinal cord segment. Okay, so the brain sometimes has problems figuring out which part of the body is actually damaged, because it is looking at all of the pain impulses that are coming in at that one particular level of the spinal cord, and is trying to figure out which one of these places actually has the damage. Okay, so it seems almost a little inefficient, but it actually can be useful in the clinical setting, because let's say somebody comes in and they're complaining of left shoulder pain, and you checked out their left shoulder and there's nothing wrong with it. Okay, well, now you know what other parts of the body you should be looking at to see if there's damage there. You need to look at all of the different parts of the body whose sensory information enters the spinal cord at that same spinal cord level. But this does illustrate that the pain experience can be affected by a lot of things, and so it's not necessarily as straightforward as we would like to think. Another thing that illustrates how confusing the pain process can be is the idea of endogenous opioids. Opioid-like substances that our own bodies produce that stimulate opioid receptors and kind of change the pain experience. I'm talking about things like endorphins and enkephalins and dynorphins. It seems like these endogenous opioids are somehow regulated through the brain stem, and they can change how pain impulses are handled or processed in the spinal cord. And so it leads to weird kinds of things, like you've probably heard of athletes who get injured during a game and they don't notice it. They don't feel any pain until the game is over, okay? Because somehow these endogenous opioids got released and changed the pain experience. Another example would be how a lot of times we find soldiers have gotten injured during a battle, but they don't feel the pain, they don't notice it, because they're so busy trying to rescue all their comrades, right? And then after the crisis is over, they go, oh, look, I'm injured, okay? Again, that probably has something to do with the effect of these endogenous opioids like endorphins and so forth. But, we don't fully really understand how that works. But both of these kinds of phenomenon show that pain is actually a pretty complicated phenomenon, and it can be affected by a lot of things. Now, when it comes to assessing pain, I know you talk a lot about that in fundamentals and skills, so I'm not going to go into a lot of detail on that. But I do want to remind you that in addition to assessing the quality and the location and so forth of the pain, we also need to be assessing the physiologic responses and the psychosocial responses to pain. When we assess physiologic responses to pain, probably what we find is going to depend on whether the patient has acute pain or chronic pain. And for purposes of this discussion, we're going to refer to acute pain as pain that lasts less than 6 months. Okay? Now, if the patient has acute pain, usually we're going to see activation of the sympathetic nervous system. You're going to see all that fight or flight stuff, right? Increased heart rate, increased blood pressure, that kind of thing. Whereas with chronic pain, which lasts longer than 6 months, we tend not to see that fight or flight type reaction. Now, this doesn't mean that chronic pain is not as painful as acute pain. What it probably just means is that this person has been in pain for so long, that they've used up all of their resources and they just don't have the energy to develop the fight or flight responses. Their body's so exhausted that it can't generate an increase in heart rate or an increase in body or increase in blood pressure. Okay, but remember, this does not mean that the pain is less severe. What it does mean is that you cannot gauge how severe the pain is just by looking at whether the patient's blood pressure or heart rate is elevated. I know it's tempting to look at a patient who's asking for pain medication and going, well, how much pain could they be in? Because, their heart rate's fine, their blood pressure's fine. But remember, we can't assess pain level based on that, because sometimes when the pain has lasted for so long, people are just so tired they can't generate that fight or flight response. When it comes to assessing psychosocial responses to pain, this also is going to depend on whether the pain is acute or chronic, because we find that acute pain tends to cause more fear and anxiety, whereas chronic pain tends to generate more depression, withdrawal, changes in appetite or changes in sleep pattern and that kind of thing. Now, when we're assessing somebody's psychosocial response to pain, you have to remember that that is going to be different from person to person, because the psychosocial response to pain is going to be affected by the patient's pain tolerance. Okay, now I'm not talking about the pain threshold, because the pain threshold is pretty much the same from person to person. We usually define the pain threshold as the intensity at which a stimulus is perceived to be painful. It is probably the same point at which that stimulus could cause tissue damage. Maybe this slide can help clarify for us a little the idea of the pain threshold. What you see is if you have a stimulus that is below the level of the pain threshold, you'll feel it, but it's not painful. Whereas if the stimulus is more intense and it's greater than the pain threshold, now it's going to be perceived as painful. And that point at which the change occurs between when you just feel it and when it feels painful, that's what we call the pain threshold. And that point is probably about the same in everybody, because that point is usually about the level of intensity of a stimulus where now tissue might be damaged. Okay, and so that is probably going to be pretty much the same from person to person. What is not going to be the same, though, is pain tolerance. Pain tolerance is defined as the intensity of stimulus at which point the person can no longer stand it without having something done about it. This is how intense of a stimulus is this person willing to endure before they want you to make it stop. Okay? And pain tolerance is very different from person to person. In this slide, you can see all the kinds of things that might affect a person's pain tolerance. Tolerance is going to vary depending on the patient's personality, what their past experience with pain is, how much stress they're currently under, what their culture expects them to do. Some cultures are very expressive, whether other cultures are supposed to be more stoic. It also depends on environmental factors. We find that a lot of times patients in the hospital feel more pain when the environment is noisy and busy, and they feel less pain when the environment is more calm. So all these kinds of things can affect what a patient's pain tolerance is. So again, just because the person looks like they're tolerating the pain well, or they're not demanding that you do something about it, that doesn't necessarily mean that their pain is less severe than somebody who is really not coping well and not tolerating the pain well. As far as interventions for pain go, I'm not going to go into detail on that either, because I know you talk about that a lot in fundamentals and skills. all I really want to say about intervention is that we really need to manage pain aggressively in order to avoid what we call the wind-up phenomenon. Now, what the wind-up phenomenon is we find that if we continually stimulate the pain fibers, over time they start to respond more intensely. In other words, we have more action potentials being triggered and transmitted to the nervous system. And what that increase in the number of action potentials does is it makes the pain be perceived as more intense, even if the actual damage to the tissues has not gotten worse. So it's sort of like, pain, we say, is the warning sign where the body is knocking at the door of your brain saying, you know what, wake up, pay attention, there's a problem here that you need to take care of. And if we don't take care of it and the pain impulses continue to come in, what happens is the body's going to start knocking louder to get your attention, to force you to do something about that. So now we have a situation where the tissue damage hasn't actually gotten worse, but the patient is experiencing the pain more intensely. This explains why it takes a lot more pain medication to get rid of the pain if the patient waits until they absolutely can't stand the pain anymore before they ask for medication. Okay? It also explains why it's a lot easier to prevent pain than to control it once it's occurred. Sometimes I get sinus headaches, and I find that if I take medication as soon as the headache starts, it goes away a lot faster than if I wait until the pain gets really bad. Then I have to take 2 or 3 different doses before the pain actually goes away, and probably related to this wind-up phenomenon. What this means is that it's very important for us as nurses to manage pain aggressively. But unfortunately, a lot of times that doesn't happen. A lot of nurses and doctors don't give pain a very high priority, probably because pain is usually not perceived as life-threatening, right? I don't think anybody's death certificate ever said that they died from pain, okay? But we actually do have a lot of research now that shows that pain can do things like inhibit your immune system, or impair your mobility, or increase the oxygen demand, increase sympathetic activity. Okay, so it is important that we manage pain in order to prevent some of these negative consequences.
All right, let's switch gears for a little bit. We started this recording by talking about the spinal cord because I felt like we needed to know a little bit about the spinal cord before we could understand how the peripheral nervous system links to the brain. Then we talked about the somatic nervous system, which is one part of the peripheral nervous system. I want to talk now about the other part of the peripheral nervous system, the autonomic nervous system, because I feel like we need an understanding of both the somatic nervous system and the autonomic nervous system before we can fully understand all the problems that go along with spinal cord injury. Because, sensory, motor, and autonomic function are impacted when the spinal cord becomes damaged. So, let's talk about the autonomic nervous system. Now you remember that we said the autonomic nervous system is in charge of maintaining homeostasis of the involuntary functions of the body, things carried out by your blood vessels and your internal organs. These are things that seem to just function automatically without you even having to think about it. Now, there are 2 things that I want to say about the autonomic nervous system before we get into all the details. The first thing is, if you look in most textbooks, they consider the autonomic nervous system to be primarily a motor system. Now, I'm actually not sure why that is, because the autonomic nervous system does have sensory input, right? How is it going to know if something is not in homeostasis and needs to be fixed if it doesn't have sensory input, right? But for some reason, the books consider the autonomic nervous system to be a motor system. So, okay, I'll go with that. But I do want you to know that the autonomic nervous system does have to have that sensory input so that it knows whether or not something is not in homeostasis anymore and needs to be corrected. Does that make sense? The other thing I wanted to say is that even though it seems like all these things that the autonomic nervous system is regulated happen on their own without you even having to think about it, your brain is thinking about it, okay? You're just not aware of it. Remember we said that the hypothalamus and the brainstem were the parts of the brain that are responsible for processing the sensory information that comes in and coordinating the autonomic nervous system to send out the correct signals to maintain homeostasis. And you know, your hypothalamus and your brainstem are part of your brain. Right? So even though it seems like these internal organs function automatically without you even having to think about it, your brain is thinking about it. It's just thinking about it in a, quote, lower brain center. Okay? Now, we are usually only consciously aware of what goes on in our higher brain centers, like our cerebrum and our cerebral cortex. That's why it seems like the autonomic stuff happens without us having to even think about it. Our brains are thinking about it, but it's thinking about it in a lower brain center, and so we're not consciously aware of that. Does that make sense? All right, so we've mentioned the autonomic nervous system several times already this quarter, so I'm sure you're aware that we divide it into two divisions, the sympathetic and the parasympathetic divisions. Okay, you've probably seen charts on the autonomic nervous system somewhere along the line during your prereq classes. And if you're like me, you've wondered, what in the world am I looking at? Okay, well, let me tell you a few things that I want you to get out of this picture. Okay, so first of all, the sympathetic division. Sometimes we call it the thoracolumbar division because you notice the nerves in the sympathetic division exit the spinal cord in the thoracic and the lumbar regions of the spinal cord. Whereas if you look at the parasympathetic division, you'll notice that most of the parasympathetic nerves are exiting the spinal cord in the cranial and the sacral regions of the spinal cord. So we call the parasympathetic division the cranial-sacral division. And by cranial, we actually mean brainstem because a lot of those parasympathetic nerves are exiting the brainstem. Another thing you can notice from this picture is that the sympathetic and parasympathetic divisions are pretty much sending impulses to the same parts of the body, right? It's just that they're sending different messages. The sympathetic division has two main jobs. Its first job is to help you maintain homeostasis of all of those automatic body functions as the needs of your body change throughout the day. You know, sometimes during the day you're being pretty sedentary, other parts of the day you're being a lot more active. And so the first job of the sympathetic division is to make sure that regardless of what your body is doing, it has what it needs to meet its needs at that moment. The second job of the sympathetic division, of course, is to generate that fight or flight response to help your body deal with stress and prepare to defend itself. And you already know what happens when you have sympathetic stimulation, right? Your heart rate and your blood pressure go up, your blood glucose goes up so that you have energy, your airways are going to dilate so you have oxygen, your pupils will dilate so you can see who you're fighting or running away from. And, you know, blood is going to shift from your skin and your GI tract to your brain and your skeletal muscles because if you're going to do the fight or flight thing, you need your brain, you need your skeletal muscles. Probably not all that important that you be digesting your food at that point. The parasympathetic division seems to do pretty much the opposite, right? We call it the rest and digest system. So its job is to conserve energy and to replace the energy stores that you've used up. So now it is important that you be digesting your food, right? So notice that they pretty much do opposite things to each other. Now look at the parasympathetic division. Okay, do you see the vagus nerve? Okay, the vagus nerve, you remember, is one of your cranial nerves, right? But notice how the majority of the parasympathetic nerve fibers are actually part of that vagus nerve. I think your book says about 75% of all the parasympathetic nerve fibers are in that vagus nerve. So for that reason, whenever you hear somebody talking about vagal stimulation, you should think parasympathetic effects. All right? All right. Another thing to notice from this picture. Notice how, okay, if you look at the sympathetic division, notice how the sympathetic nerves, after they leave the spinal cord, are going to synapse with another nerve in a ganglia before they travel on to their target tissue. Now, the word ganglion can have several different meanings depending on what context you're using it in. But when we're talking about the nervous system, a ganglion is just a mass of nerve tissue that's located outside the central nervous system. Okay, and of course, the plural of ganglion is ganglia. Okay, so if we go back to this picture, do you see the chain of sympathetic ganglia that's located to the right of the spinal cord? Okay, so when the sympathetic nerve exits the spinal cord, it synapses with another nerve in that ganglia before it travels on to the target tissue. So what that means is there are two nerves in the pathway between the spinal cord and the target tissue in the sympathetic division. There's a preganglionic nerve that starts in the spinal cord and ends in the ganglia, and then there's a postganglionic nerve that starts in the ganglia and travels on to the target tissue. Now, in the parasympathetic division, we do have the same setup. There are two nerves in the pathway between the spinal cord and the target tissue. There's a preganglionic nerve and a postganglionic nerve. But it's harder to see in the parasympathetic division because in the sympathetic division, the preganglionic neuron is very short and the postganglionic neuron is very long. And so you can see that where the synapse is in that ganglia right next to the spinal cord. But in the parasympathetic division, it's the opposite. The preganglionic neuron is really long and the postganglionic nerve is really short. And as a matter of fact, a lot of times the preganglionic nerve is so long that the synapse actually occurs inside the target tissue. Okay, so it is harder to see in the parasympathetic division. But the point I'm trying to make here is in both the sympathetic and the parasympathetic divisions, there are two nerves in the pathway between the spinal cord and the target tissues. There's a preganglionic neuron and a postganglionic neuron. So here you can see kind of a diagram of, the pathway between the spinal cord and the target tissue in the autonomic nervous system. And you notice that in the parasympathetic division and the sympathetic division, there are two nerves, right? A preganglionic nerve and a postganglionic nerve. And you can compare that to the somatic motor system, which is drawn in on the bottom. You notice that there's only one nerve on that pathway between the spinal cord and the target tissue. That would be the lower motor neuron. Okay, but in both the sympathetic and the parasympathetic divisions, there are those two nerves, the preganglionic nerve, which synapses with a postganglionic nerve in the ganglion, and then it goes on to the target tissue. Now, maybe you're wondering why we care that there are ganglia and that there are synapses. Okay, the reason why we care is because whenever you have a synapse, that's a place where neurotransmitters are being released and receptor sites are being stimulated, and that's a place where we could potentially change what's happening by giving a medication to either stimulate or block that receptor site. Does that make sense? So let's talk about those synapses and look at which neurotransmitters are released and which receptors are located at each of those synapses. Okay, so there are 5 places that you're going to find synapses in the peripheral nervous system, and you see them in this picture. Okay, in both the sympathetic and the parasympathetic divisions, there is a synapse between the preganglionic nerve and the postganglionic nerve, right? And then there's a synapse between the postganglionic nerve and the target tissue. In the somatic motor system, there's only a synapse between the lower motor neuron and the skeletal muscle. Okay, so those are the 5 different places that you're going to find synapses in the peripheral nervous system. Now, there are 3 neurotransmitters that are active in the peripheral nervous system. We have acetylcholine, and then we have 2 catecholamines, epinephrine and norepinephrine. Let's look back at our picture and see which neurotransmitters are released at which synapses. All right, now notice that acetylcholine is being released at the synapse between the pre- and the postganglionic nerves in both the sympathetic and the parasympathetic divisions. Okay, so that's already 2 synapses that are using acetylcholine. Acetylcholine is also being used at the synapse between the postganglionic nerve and the target tissue in the parasympathetic division. Okay, so that's a 3rd synapse. And then finally, we see acetylcholine being used at the synapse between the lower motor neuron and the skeletal muscle in the somatic motor system. Okay, so that's 4 of the 5 synapses in the peripheral nervous system that use acetylcholine, which means the only synapse in the peripheral nervous system that uses epinephrine and norepinephrine is the synapse between the postganglionic nerve and the target tissue in the sympathetic division. Okay, so what that means is epinephrine and norepinephrine are only used in the sympathetic nervous system. Okay, so if you hear somebody talking about epinephrine and norepinephrine being released, you know we're talking about the sympathetic nervous system. Okay, if they talk about acetylcholine being released, they could be talking about any of these 3 parts of the peripheral nervous system, right? Because acetylcholine is used in all 3 of those divisions. But epinephrine and norepinephrine are only active in the sympathetic nervous system. Does that make sense? All right, what about the receptor sites? There are 2 main kinds of receptors that operate in the peripheral nervous system. We have cholinergic receptors and adrenergic receptors. Now, it's pretty obvious where the term cholinergic came from, right? Because it sounds like acetylcholine. So the cholinergic receptors are the ones that bind acetylcholine. Where do you think the term adrenergic came from? It actually came from the other name that epinephrine and norepinephrine goes by, which is adrenaline and noradrenaline, right? So the adrenergic receptors bind epinephrine and norepinephrine. So if we go back to our little picture, now we know that we have cholinergic receptors at 4 of these 5 synapses, and we only have adrenergics in the sympathetic nervous system, right? Because the catecholamines, epinephrine and norepinephrine, are only used in the sympathetic system, so the receptors that bind epinephrine and norepinephrine are only found in the sympathetic system. Now, if we could just stop there, everything would be so easy. But no, we have to go and subdivide cholinergic and adrenergic receptors. So let's talk about the cholinergic receptors first. We divide the cholinergic receptors into 2 subtypes. We have nicotinic receptors and muscarinic receptors. Now, remember we had 4 of the 5 synapses in the peripheral nervous system that had cholinergic receptors. And of those 4 places, 3 of them have nicotinic receptors. Okay? So all 3 of these systems have nicotinic receptors. Only one of those 3 systems has muscarinic receptors. The only place that you have muscarinic receptors is at the synapse between the postganglionic nerve and the target tissue in the parasympathetic division. Okay? So if we're talking nicotinic receptors, It could be any of these three divisions that we're talking about. But if we talk about muscarinic receptors, you know we're talking about the parasympathetic system. Does that make sense? Now, we already said that you only have adrenergic receptors in the sympathetic division, right? So if we put that all together, okay, so here you can see which kinds of receptors we have at each of the 5 synapses. We have muscarinic receptors only at the target tissue in the parasympathetic division. We have adrenergic receptors only at the target organ in the sympathetic system, but we have nicotinic receptors in all 3 of those divisions. Got it? And here we have it in writing if it's easier for you to grasp that way. Now, we also subdivide the adrenergic receptors into alpha 1, alpha 2, beta 1, and beta 2 receptors. And those adrenergic receptors are all found in different tissues of the body. Okay, so let's talk about where each of those kinds of receptors is primarily found. Let's talk about the beta 1 and the beta 2 receptors first. Okay, the beta 1 receptors are primarily found in your heart. So if you stimulate the beta 1 receptors, what do you think is going to happen? Well, you get sympathetic stimulation to your heart, so the heart rate is going to go up, right? Increase heart rate, increase force of contraction. The beta 2 receptors are usually found in the airways of your lungs. And a lot of people remember that by thinking, you have one heart and you have 2 lungs. So beta 1 goes with the heart, beta 2 goes with the lungs. Okay, when you stimulate beta 2 receptors, you get sympathetic effects in the lungs. Okay, so sympathetic effects in the lungs are going to cause what? Are you going to bronchodilate or bronchoconstrict? You're going to bronchodilate, right? Because if you're going to do the fight or flight thing, you need oxygen for your muscles to do that. So your airways are going to dilate. Alpha 1 receptors are primarily located in the smooth muscle of your blood vessels. Okay, so that picture is supposed to be a blood vessel. Okay. Now, if you have sympathetic stimulation to the alpha 1 receptors in the smooth muscle of your blood vessel, what do you think is going to happen? They're going to vasoconstrict, right? And if you vasoconstrict, what's going to happen to your blood pressure? It's going to go up. Now, we've already said that when you stimulate alpha 1, beta 1, and beta 2 receptors, you get sympathetic effects. Alpha 2 is the different one, because when you stimulate alpha 2 receptors, you turn down sympathetic effects. Okay? So you remember we said that the body's really good at always having a system of checks and balances to make sure nothing gets out of control, right? The alpha 2 receptors are part of that system of checks and balances. The alpha 2 receptors are located in your central nervous system, and they're kind of there as an indicator so that the central nervous system can tell how much sympathetic stimulation is already going on out there in the body. Okay? When the alpha 2 receptors start to get stimulated, that tells your brain, you know what? There's a whole lot of sympathetic stimulation going on there. We probably need to start turning it down so it doesn't get out of control. Okay? So we sometimes refer to alpha 2 receptors as providing feedback inhibition. Okay? In other words, it's giving feedback to the central nervous system so it knows when it needs to turn down the sympathetic stimulation so it doesn't get out of control. Got it? Now, we really only talked about the primary locations for those different kinds of adrenergic receptors. But there are other places in the body where you're going to find a few here or there. Okay? So, if you were interested, you could look in a pharmacology book and you could find a list like this where it's going to tell you pretty much all the places in the body where you might find an adrenergic receptor and, where it's located, what it does, all that kind of thing. I don't expect you to learn all of that stuff. I just want you to know that if you are interested in it, you can find charts like this. All I really want you to know is that the sympathetic and the parasympathetic divisions sort of oppose each other as far as they cause the opposite effects. And I want you to know the sympathetic is the fight or flight and the parasympathetic is the rest and digest. And, I want you to know any of the sympathetic and parasympathetic effects that we talked about as we talked about the cardiovascular, the respiratory, and the GI system, but you don't need to know it in this much detail. All right? Now, maybe you're thinking, I still don't understand why I should care about autonomic nervous system, synapses, and all that kind of stuff. Well, let me tell you, you're mostly interested in it from the standpoint of understanding the autonomic nervous system drugs. Because, autonomic nervous system drugs are not just used to treat autonomic nervous system diseases. Autonomic nervous system drugs are used to treat almost all your major body systems. Because remember, the sympathetic and the parasympathetic divisions send impulses to all your major body organs, right? And so we will often treat heart disease, lung disease, GI disease with autonomic nervous system drugs. So you'll see them over and over. When you get to pharmacology, you'll talk in a lot more detail about them. So if you understand it now, it'll make it that much easier when you talk about all those autonomic nervous system drugs in the future. So to put it in a really small nutshell, there's really only two things you need to know about an autonomic nervous system drug in order to know what it's going to do, who should take it, and who should probably not take it. Those two things that you need to know are, what receptor sites does this drug affect, and does it stimulate or block those receptors? Okay, so we're going to walk through a few examples using those two questions. But before we do that, there's a couple of terms that we probably need to clarify first. Those two terms are agonist and antagonist. Okay, an agonist is a drug that stimulates a receptor site, and an antagonist is a drug that blocks a receptor site. Okay, so in this analogy, you have a hormone or a neurotransmitter that binds to a receptor site, and it's like a key that's going to open the lock. Okay, an agonist is not that hormone or neurotransmitter, but it can do the same thing, okay? It can stimulate that receptor site and get the same effect. Just like you can use that hairpin and stick it in the lock and unlock the door, just like you did with the key, okay? An antagonist, on the other hand, is going to block a receptor site. And so nothing else can bind to that receptor site and stimulate it. So not only is that antagonist not going to stimulate that receptor site, but it's going to prevent anything else from stimulating that receptor as well. So in this analogy, the antagonist is like a stick that we jam into the lock, and so now nothing else can go in that lock and unlock it. Does that make sense? All right, let's look at some examples. Let's say we have a drug that is an alpha-1 antagonist. Sometimes we call them alpha-1 blockers because an antagonist blocks the receptor sites, right? Okay, so where are your alpha-1 receptors found? In the smooth muscle of your blood vessels, right? And if you have sympathetic stimulation to the alpha-1 receptors, what's going to happen? You're going to vasoconstrict, right? So what's going to happen if you block those alpha-1 receptors? You're going to get vasodilation, right? So who would benefit from taking an alpha-1 antagonist? Probably somebody with hypertension, right? Because if you vasodilate somebody with hypertension, their blood pressure will drop, right? Do you see how this works? All right, let's try another one. Let's say you have a beta 2 agonist, okay? Where are your beta 2 receptors found? In the airways of your lungs, right? And does an agonist stimulate or block that receptor? It stimulates it, okay? So if you have stimulation of your beta 2 receptors in your lungs, what happens? You bronchodilate, right? Because beta 2 receptors, you get sympathetic stimulation. Sympathetic stimulation is going to bronchodilate the airways so you can get more oxygen in to do that fight or flight thing, okay? So if a beta 2 agonist is going to bronchodilate you, who would be a good patient to give a beta 2 agonist to? People with asthma, people with COPD. Okay, do you see what we're doing here? All right, what about a non-selective beta blocker? Okay, non-selective means that this drug is not picky. It's going to block both beta 1 and beta 2. Okay, so where are your beta 1 receptors found? In your heart, right? And if you were to stimulate beta 1, what would happen? Your heart rate would go up. So if you block beta 1, what's going to happen? Your heart rate goes down. Okay, so who is a good patient to receive this drug? Maybe somebody with hypertension, right? Because if you slow the heart rate, the blood pressure should decrease. Or maybe somebody with angina, right? Because if you slow the heart rate, that decreases the workload of the heart and the chest pain should go away. Okay, but remember, this is a non-selective beta blocker, so it's not just going to block beta 1, it's also going to block beta 2. So where are your beta 2 receptors? In your lungs. And if you stimulate beta 2, you get bronchodilation. So if you block beta 2, what's going to happen? You get bronchoconstriction. Okay, so who should not receive this drug? Somebody with asthma, somebody with COPD. Okay, so do you see what I mean when I say you can predict who should take the drug as well as who should probably not take it, right? All right, what about an alpha 2 agonist? Okay, where are your alpha 2 receptors found? In the central nervous system, right? And does an agonist stimulate or block that receptor? It stimulates it. Okay, so do you remember what happens when you stimulate the alpha 2 receptors? Remember, the alpha 2 receptors, when you stimulate them, they're going to turn down sympathetic stimulation, right? So what do you think is going to happen to the blood pressure of somebody who takes an alpha 2 agonist? It's going to decrease, right? Because if you turn down sympathetic stimulation, that's going to decrease the blood pressure, right? So do you understand now why we might give somebody with hypertension either an alpha 1 antagonist or an alpha 2 agonist, right? People, when they're in Adult Health 1 and we study antihypertension meds, they always get confused. You know, why do we give an alpha 1 antagonist and an alpha 2 agonist? That seems contradictory. Okay, and I always just say, remember what we talked about in patho, right? The alpha 1 receptors give you sympathetic effects. Alpha 2 receptors turn down sympathetic effects. Make sense? All right, let's try one last one. How about a muscarinic antagonist? Okay, so do you remember where your muscarinic receptors are? Remember, the muscarinic receptors are at the target tissue in the parasympathetic division, right? So if you stimulate muscarinic receptors, you are going to get parasympathetic effects. However, we're talking about a muscarinic antagonist, right? We're talking about a drug that's going to block the muscarinic receptors. So we're going to block parasympathetic effects, okay? Sometimes instead of calling them muscarinic antagonists, you'll see us calling them anticholinergic, right? The cholinergic referring to the fact that we use acetylcholine in the parasympathetic division, and we're blocking that, right? So anticholinergic, we're blocking parasympathetic effects. So when you read drug books, sometimes your drug book will say, oh, a muscarinic antagonist has anti-parasympathetic effects. Okay, now if you think about that, anti-parasympathetic effects, if we're blocking parasympathetic effects, that actually says the same thing as causing sympathetic effects, right? So anti-parasympathetic effects is basically the same thing as what you get when you have sympathetic stimulation. Okay, now I know that's kind of like mental gymnastics, but think about that for a little bit, and I think it'll make sense to you, right? So when we give an anticholinergic drug or a muscarinic antagonist, we're actually blocking parasympathetic effects. We're causing effects that are like sympathetic stimulation. Okay, let me give you an example of a situation in which I used to give a lot of anticholinergic drugs. I used to work on a neuro unit, and we used to send a lot of patients for cerebral angiograms to see how much atherosclerosis was in their cerebral arteries. Okay, and one of the things that frequently happened during that procedure is that people's heart rates would drop really low during the procedure to the point where we were worried about their cardiac output. So what the doctors would always order before this procedure was a dose of anticholinergic drug or muscarinic antagonist, because that drug would increase the heart rate, and that would prevent the patient's heart rate from dropping too low during the procedure. Does that make sense? Actually, I want to do one more, okay? Let's talk about a neuromuscular blocker. So a neuromuscular blocker is going to work at the neuromuscular junction in the somatic motor system. So that synapse where you see that red arrow pointing at. A neuromuscular blocker is going to block the receptor site at that location on the skeletal muscle. So if the receptor sites on the skeletal muscles don't get stimulated, what do you think is going to happen? Yeah, they don't contract. So what are we basically doing to this person? We're paralyzing them, right? And weird as it sounds, there are some actual uses for neuromuscular blockers. For example, sometimes in the ICU, when we have patients on the ventilator, some patients will actually fight the ventilator because the ventilator is kind of like forcing air into the patient's lungs, and the patient may not want to breathe when the ventilator is trying to inflate their lungs. The patient wants to breathe when they want to breathe. And so sometimes we actually kind of have to paralyze people so that the ventilator can be the most effective. Okay? Another time we might use it is during an abdominal surgery. The neuromuscular blocker can sometimes be used to relax those abdominal muscles so that we can spread them apart and the surgeons can actually see into the abdominal cavity and be able to see what they're doing, right? Now, the neuromuscular blockers, I understand, are also part of the lethal injection in some states when they do executions, right? So, yeah, that's probably not the use of neuromuscular blockers that we will see in our practice, but, it's an interesting little factoid, right? One last comment I have on autonomic nervous system drugs, and that is we don't often give drugs to stimulate or block the nicotinic receptors in the sympathetic and parasympathetic division because, there are nicotinic receptors in both the sympathetic and parasympathetic divisions. So if you stimulate them or you block them, you're going to get very unpredictable results because what it's doing in the sympathetic division is kind of opposing what it's doing in the parasympathetic division. And anyway, we used to have some antihypertensive drugs that worked at that kind of receptor, and we don't use them anymore because they were very unpredictable and had a lot of side effects. And anyway, you get what I mean. right? All right, now we're ready to talk about spinal cord injury. And what we're going to talk about is traumatic damage to the spinal cord, the kind that results from accidents and stuff rather than disease. Now, as you might imagine, if the spinal cord gets injured, you expect to see problems with the two functions that we said the spinal cord has, right? So we're going to expect to see changes in the transmission of nerve impulses between the brain and the peripheral nervous system. And we expect to see changes in spinal reflex activity. Now, the degree of disability that results from a spinal cord injury depends basically on two things: how high or low on the cord the damage occurred, and whether or not the injury was a complete or an incomplete injury. Let's talk about complete versus incomplete injury first. A complete spinal cord injury means that pretty much the entire width of the cord has been damaged, so that no nerve impulses are able to be transmitted past that level of the injury. An incomplete spinal cord injury means that there are parts of the spinal cord that have escaped injury, and so there is some nerve transmission possible below the level of that injury. And in this picture, you can see some examples of where you might see part of the cord damaged and another part spared, so that nerve transmission is still possible in the undamaged areas. Whereas in this picture, you can see that pretty much the entire width of the cord has been damaged, and so there is not going to be any nerve transmission below the level of that injury. Unfortunately, the large majority of spinal cord injuries are complete injuries because of the way the vertebral column is set up. You remember the vertebrae are pretty much stacked one on top of the other, right? And there is a hole in the middle of the vertebrae that the spinal cord goes down through. Now, if during an accident two vertebrae happen to get separated from each other and they get pushed in opposite directions, okay, what's going to happen to the spinal cord that goes down through the middle of those? The spinal cord is going to pretty much get crushed, right? And that's going to damage the entire width of the cord. So that does mean the majority of spinal cord injuries are complete. Although there are instances where, maybe there's a gunshot wound or a stab wound and maybe only half the cord is damaged. And that's when you might see one of these kinds of scenarios. Unfortunately, we can't always tell right away when a patient comes into the emergency department whether the injury is a complete or an incomplete one, because even if it's an incomplete injury, there's usually so much swelling in the spinal cord that the swelling impairs nerve transmission, and so we always hope that as the swelling goes down, we might see some nerve transmission resume in parts of the cord that might be uninjured, and we might start seeing some function below the level of the injury. But like I said, the large majority of spinal cord injuries are complete just because of the way the vertebral column is constructed. The other thing that we said is going to affect the degree of disability a spinal cord patient will suffer is how high or low on the cord the damage occurs. Because of the spinal cord's role in transmitting nerve impulses between the brain and the rest of the body, and because we said that when you damage the spinal cord, that's going to affect nerve transmission at and below the level of the injury, what that means is the higher on the cord the damage occurs, the more of the body the brain is going to lose touch with, and the more disabled the patient's going to be. Does that make sense? So if you have somebody who has an injury fairly high on the cord, they will probably have what we call quadriplegia, because quad means 4, right? And so we have all 4 extremities that are affected. Sometimes we also call quadriplegia tetraplegia, because tetra also means 4. If the injury is lower down on the cord, we might see only the lower half of the body be affected, and we would call that paraplegia. Okay, so notice when we're talking about spinal cord injuries and we're talking about half the body, we're talking upper half versus lower half. Whereas remember when we were talking about strokes and we talked about half the body, we were talking about right half versus left half, right? So you remember we talked about dermatomes as being kind of maps that tell us which spinal cord segments and the spinal nerves that exit those segments innervate different parts of the body. And because of these maps, we can pretty much tell how impaired a spinal cord patient is going to be, as long as we know at what level their spinal cord was injured. So when I worked on a neuro unit, we had a big poster of this slide hanging in our report room. And when we knew we were going to get an admission who had a spinal cord injury, we would go into the report room and look at this poster, and we could anticipate what our patient would and would not be able to do. Now, I don't expect you to memorize this chart, but I'm going to kind of summarize it for you, and I will expect you to be familiar with the summary. Okay? So, if the patient's injury is above the C4 level, pretty much the only thing you can expect that patient to be able to do is to have good head control. Okay, this person probably won't even be able to breathe on their own because at that level, the brain will no longer be able to send impulses to your diaphragm, which is your main respiratory muscle, right? So if the injury is above the C4 level, the patient will probably need some degree of ventilatory assistance. Now, you guys might be too young to know who this is, but this is Christopher Reeves, and he actually played Superman in a bunch of movies back in the old days. But anyway, he had a spinal cord injury that he got when he fell off a horse, I believe. And his injury was right at the C4 level. So he was partially ventilator dependent, meaning that when he was awake, he could breathe on his own, but at night when he went to sleep, he needed to be on a ventilator. Now, if the injury was below C4, but still in the cervical region, the patient should be able to breathe on their own, and they should have good shoulder and elbow function, although they probably won't be able to use their fingers. Now, people can actually do quite a lot with shoulder and elbow function, even if they can't use their fingers. For example, we used to fit these patients with really stiff leather gloves, and their wheelchairs would have pegs on the wheel rims, so they could actually push themselves around the unit by bracing their hands against the pegs and just using their shoulders and elbows to push forward. We also had them fitted with special gloves that had that we could attach built-up forks and spoons with built-up handles. Okay, and then they had a plate guard on their plate that would keep food from falling off the end. So just by using their shoulders and their elbows and these utensils that were attached to their gloves, they could push food against the plate guard, and that would push the food onto their fork or spoon, and then they could use their shoulder and elbow function to feed themselves. So these people could also feed themselves. Now, if the injury was in the thoracic region, the patient should have full use of their arms, and they would have varying degrees of trunk control. The lower down in the thoracic region the injury was, the more trunk control they would have. And the trunk control was important more from the standpoint of whether they would be able to sit in their wheelchair without being strapped into it. If it was a high thoracic injury and they didn't have much trunk control, then they wouldn't have good balance, and they might be sitting in their wheelchair and then just sort of have their upper body flop forward because they couldn't balance their trunk. So those patients, we would have to kind of put straps around their chest and the back of the wheelchair to keep them in the upright position. By the time we get down to the lumbar levels, Now we're seeing differing levels of impairment in the lower extremities. The lower down in the lumbar region the damage occurred, the more control the patient should have over their legs. And by the time you get down to the sacral levels, we would see somebody who had full use of their arms and legs, but would probably not have bowel or bladder control or sexual function. Let's talk more specifically now about exactly how a spinal cord injury is going to affect a person's functional abilities. And to do that, we probably need to review a little bit about how the spinal cord is set up. I couldn't find a picture that showed exactly what I wanted to talk about, so I drew my own picture. And obviously I'll never make my living as a medical illustrator, but I hope you'll at least get what I'm trying to show you. So the first thing that I want you to notice in this picture is that at every level of the spinal cord, in other words, in each spinal cord segment, there is an upper motor neuron that starts in the brain and ends in that spinal cord segment, where it synapses with a lower motor neuron that's going to travel to the muscles and carry out whatever command the brain sent through those motor neurons. Okay, so in this picture, I've made the upper motor neurons red and the lower motor neurons green. So you can see that every spinal cord level, we have upper motor neurons coming down, synapsing with a lower motor neuron that's then going to carry out the motor activity. Does that make sense? Also notice that at every level of the spinal cord, in other words, in every spinal cord segment, there is a sensory nerve that's going to enter, bringing in the sensory input from the different parts of the body, and that sensory nerve is also going to synapse with the lower motor neuron, and that forms the spinal reflex, right? And remember, sensory information comes in, it synapses with the lower motor neuron carries out the reflex activity without any need for input from the brain, right? So in this picture, I have made the sensory nerves light blue, so you can see that the sensory nerve also synapses with the green lower motor neurons, and that forms the reflex arc, right? All right, now that we have that down, let's talk about how the spinal cord injury is going to affect function in the spinal cord above the level of the injury, at the level of the injury, and below the level of the injury. Okay, so let's start with above the level of the injury. Everything above the level of the spinal cord injury should function perfectly normal, right? So sensory information should be able to come into the spinal cord and go up to the brain. So we should have full sensation. Motor impulses should be able to come down from the brain and go out to the body. So we should have full voluntary motor function. And sensory nerves should be able to come in and synapse with those lower motor neurons. So we should have full spinal reflex activity, right? So just to summarize, above the level of the injury, everything works fine, right? What about at the level of the injury? In that spinal cord segment that has been damaged, nothing should be happening there, right? Because that damage to that spinal cord segment has pretty much messed up any synapses that are supposed to occur there, right? So at that level of the injury in that spinal cord segment, sensory information cannot come in and synapse with a sensory nerve that's going to take that information to the brain. So there's no sensory information coming in. Okay, motor impulses can come down from the brain but cannot synapse with the lower motor neuron, so there should be no voluntary motor movement either, right? And since there's damage to that spinal cord segment, the sensory nerves can't synapse with the lower motor neuron anymore because that synapse has been damaged. So there should be no reflex activity there either, right? So at the level of the injury, nothing works. No sensory input, no voluntary motor control, no reflex activities. it's below the level of the injury that things get kind of interesting now, right? So, below the level of the injury, can sensory information come into the spinal cord and get carried up to the brain? No, because the impulses are going to hit the injured segment and get stopped, right? No nerve transmission can get past that level of the injury. So below the level of the injury, there is no sensory perception, okay? Can motor impulses come down from the brain and go out to the body below the level of the injury? No, right? Because the motor impulses are coming down from the brain, but they can't get past the level of the injury either, right? The nerve transmission is blocked below that level, and so there's not going to be any voluntary movement below the level of the injury. But can sensory information come in on a sensory nerve and synapse with a lower motor neuron to carry out that reflex activity? Yes, right? Because remember, the spinal reflex doesn't need any input from the brain. It can operate just by having the sensory nerve synapse with the lower motor neuron. So below the level of the injury, there is no sensation, there is no voluntary movement, but there is still reflex activity. So, if you need to see it in writing, there it is in the chart. Above the level of the injury, everything works great. At the level of the injury, nothing works. Below the level of the injury, there is no sensation, there is no voluntary movement, but there is still spinal reflex activity. Now, sometimes we divide spinal cord injuries into what we call upper motor neuron and lower motor neuron injuries. If we damage anywhere on the spinal cord, we consider that an upper motor neuron injury, because you remember from our little diagram that there are upper motor neurons that start in the brain and come down to each spinal cord segment, right? Which means that there are upper motor neurons that are running down the entire length of that cord. If you damage anywhere on the spinal cord, you are damaging some upper motor neuron somewhere. Okay, so if you damage anywhere on the spinal cord, we consider that an upper motor neuron injury. Okay, and with the upper motor neuron injuries, as long as the lower motor neurons are intact, you are going to have spinal reflexes, right? So what that means is a lot of times people with spinal cord damage, they might have something that triggers a reflex activity, and you might see, something move. Okay, a lot of times I used to see patients when we're changing their linens, a sheet or something would brush against their foot, and that would trigger a spinal reflex, and their toe or their foot might jerk. Okay, that was a spinal reflex, but the patients might notice that and go, oh, did you see that? My foot moved. I'm going to walk again, and you're kind of like, well, actually, that was a reflex, you feel really bad because you hate to take away people's hope, right? But you can't let them go on thinking that, that was a voluntary movement. So, it can be hard sometimes working with spinal cord patients. But the point here being that if you damage anywhere on the spinal cord, that's an upper motor neuron injury, and as long as the lower motor neurons are functioning intact, there can still be reflex activity. Now, it is possible to damage only lower motor neurons, and if that were to happen, we would call it a lower motor neuron injury. The way lower motor neuron injuries happen is to injure your back below the level of where the spinal cord ends. So you remember in this picture, the little black arrow is pointing to where the spinal cord ends. And remember we said that the spinal canal is not empty, after the spinal cord ends, right? What's in that vertebral canal after the spinal cord ends? It's the cauda equina. And remember, part of the cauda equina is made up of lower motor neurons. Okay, so if you damage the back below the level of where the spinal cord ends, and in most people that would be around the T12L1 vertebrae, okay? So if you damage below the T12L1 vertebrae, the spinal cord's already ended, so the spinal cord does not get injured. What gets injured is the cauda equina, and now we're only damaging lower motor neurons, no upper motor neurons. And so we would call that a lower motor neuron injury. Now, can you have reflex activity if you damage the lower motor neurons? No. Right? Because in order to have a reflex, you have to have the sensory nerve synapsing with a lower motor neuron in the spinal cord, and then the lower motor neuron carries out the reflex activity. If you damage the lower motor neurons, then you can't have any spinal reflexes, and so that's the main difference between the upper motor neuron and the lower motor neuron injury, is that in the upper motor neuron injuries, you still have spinal reflexes below the level of the injury. In a lower motor neuron injury, there are no spinal reflexes below the level of the injury. Does that make sense? So with the upper motor neuron injuries, we sometimes refer to it as spastic paralysis. The spastic term referring to the fact that there are still spinal reflexes. The lower motor neuron injuries we usually refer to as flaccid paralysis to indicate that there are no reflexes, there's usually going to be poor muscle tone, there'll be no spasms, and usually over time we're going to see atrophy of the muscles because there aren't any reflex movements that might be triggered, and so the muscles will just totally atrophy. Now, maybe you're wondering why we care whether the patient has flaccid or spastic paralysis, whether or not there's reflex activity or not. Primarily, we care in terms of how the bowel and bladder empty. Because if you think about it, if there is reflex activity, we can get the bowel and the bladder to empty on reflex. And, of course, the patient still is incontinent, right? Because they don't have voluntary control. But at least we don't have to keep sticking a urinary catheter in this person's bladder every 4 hours. Because every time we stick a urinary catheter in there, no matter how careful we are with trying to, maintain sterile technique, there is the possibility that we're introducing organisms and the patient could get a UTI. So if we can get away with not catheterizing them, that of course is the best way. Now, if there is no reflex emptying, then you can't trigger the bladder and the bowel to empty on reflex, and everything just kind of sits there, right? So on the neuro unit where I used to work, we would do some spinal cord rehab, and with our upper motor neuron patients that had reflex activity, we would try to do bowel and bladder training. Okay, so what we would do with the bladder training is we would provide some sort of stimulus and then straight cath the patient, okay, empty their bladder. And, the stimulus might be we would tap on their lower abdomen over their bladder. Or, sometimes we would just pull on their pubic hair or something. But anyway, we would provide a stimulus and then we would insert the catheter and drain the bladder. And eventually, in a lot of our patients, we could get to the place where all we would have to do is provide the stimulus, tap over their bladder, and the bladder would empty on reflex. Okay? Now, it is, of course, possible that somebody might tap on their bladder accidentally and they would have an accident, but at least we could cut down on the amount of catheterization we would have to do. And a lot of times, if we could get somebody to empty their bladder on reflex, they would at least have a couple of hours where they wouldn't have to worry about having an accident. With the bowel training, what we would do is every morning after breakfast, because after you eat is when you get that GI reflex where the bowel just wants to empty. So to take advantage of that, we would, do the bowel training after breakfast. We would stimulate the external anal sphincter, like with a gloved finger. You just stimulate the sphincter, and then we would insert a suppository, and that would make the bowel empty. And eventually we could get to where we could just stimulate the sphincter, and the bowel would empty on reflex. And again, it's not voluntary control, but if we could get the bowel to empty, then the patient wouldn't have to worry about having an accident for several hours. Now, if there's no reflex activity, how do you think you get the bladder and the bowel to empty? Well, you'd have to catheterize the bladder, right? How do you think you get the bowel to empty? You have to go in there and manually evacuate it, right? So now do you care whether there's reflex activity or not, whether it's spastic or flaccid paralysis? Okay, the only good thing about the situation was, if you have lower motor neuron damage, that usually means the damage is below the spinal cord, it's below the level of the spinal cord where the injury occurred, right? And so the patient should have full use of their arms, and we can teach them to catheterize themselves, and we can teach them to do their own bowel program. But, still, it makes a big difference to the patient themselves what kind of bowel and bladder program they're going to be on. Now, just to clarify, neither the upper motor neuron or the lower motor neuron patient has voluntary control over their bowel and bladder, right? So they're all, quote, incontinent. Okay, it's just that when there's reflex, we can hopefully do some bowel and bladder training. If there's no reflex, then we have to manually remove the urine and the stool somehow. Okay, now that doesn't mean that the patient with the lower motor neuron injury who has no reflexes, that doesn't mean that they have no accidents, right? Because what happens is, if the bladder gets over full, it will dribble, right? So once the bladder gets full, now you're going to have what we call overflow incontinence. So it's not like, if you don't catheterize this person, the urine stays in there forever. Eventually it'll come out, and, then the person will just sort of constantly dribble. So that's not any more convenient than having the potential for a reflex to get triggered and to have an accident that way. Does that make sense? Okay, so the main thing to remember is that with the upper motor neuron injury, you can have reflex emptying. With the lower motor neuron injury, you're going to have retention. Okay, and both of those have implications for how we're going to handle bowel and bladder care for those patients. Does that make sense? Now, remember, in addition to the sensory and the motor nerves that are traveling up and down the spinal cord, there are also autonomic nerves that are traveling down the spinal cord. And when you damage the spinal cord, that's going to interrupt the transmission through those autonomic nerves. And so now there might be a problem maintaining homeostasis. For example, a lot of patients with spinal cord injury have postural hypotension, okay? Because, most of the time when people go from a lying down to an upright position, okay, the blood wants to kind of pool in the lower extremities just because of gravity, right? But when a person goes from that lying down to the upright position, if their autonomic nervous system signals are getting through It's going to tell the vessels in your lower extremities to constrict. That'll prevent the blood from pooling in your lower extremities, and so the blood doesn't all rush to your feet and you don't get all dizzy and your blood pressure doesn't drop and you don't faint. Okay? In patients with spinal cord injuries, the brain is sending out those sympathetic signals to vasoconstrict the vessels in the lower extremities, but the signals don't make it there because of the spinal cord injury. The signals never make it past the level of the injury, and so the vessels in the lower extremities don't constrict. When we put patients in the upright position, blood tends to rush to their legs, and they do get dizzy and their blood pressure does drop a little, and sometimes they pass out. Okay, so because we know this, we have to make sure that we never sit people up all of a sudden. We usually actually put like fairly tight support stockings on our patients before we sit them up. We usually also put an abdominal binder on them, which is just like a really thick piece of wide elastic that it's almost like a girdle that we're putting on people. It's this big, thick, strong piece of elastic that we will overlap over their stomach and then fasten with Velcro. And the support stockings and that abdominal binder help prevent all the blood from pooling in the lower extremities when we sit people up. And so, we kind of gradually get them used to it. So we put on those support stockings in the abdominal binder, and the first day we might raise their head just a little bit. And then the second day we'll raise it a little bit more, and we work them up till eventually we can sit them upright in their wheelchair without having them pass out. Okay, so people with spinal cord injuries do have a lot of problems with that postural hypotension. We have to be really careful when we, sit the person up so that they don't get dizzy and pass out. People with spinal cord injuries may also have trouble regulating their body temperature because usually the hypothalamus controls temperature by using autonomic nervous system signals. Okay, so if somebody with an intact nervous system got really cold, okay, their autonomic nervous system signals would go out and tell their blood vessels to constrict so that they can conserve heat, and telling their muscles to shiver so they can generate heat, and in that way they can try and keep their body temperature normal. Okay, on the other hand, if that person with a normal nervous system went somewhere that was really hot, then those autonomic signals are going to go out telling their blood vessels to vasodilate so that we can get rid of some of that heat, and telling their body to sweat so that they can lose heat through evaporation. And in that way, again, they can keep their body temperature within normal limits. Now, if you have somebody with a fairly high spinal cord injury, those autonomic signals are going to go out, but are not going to get past the level of the injury. And again, if the injury is fairly high, the brain will have lost touch with enough of the body's blood vessels that they may no longer be able to control the body temperature. Okay, so if the person with the high spinal cord injury went somewhere cold, they might vasoconstrict and shiver above the level of the injury, but not below. And so they would have a much harder time keeping their body temperature within normal limits. Does that make sense? On the other hand, if that person with the high spinal cord injury went somewhere really hot, the vessels above the injury would vasodilate and they would sweat above the injury but not below. So again, they would have more trouble maintaining their stable body temperature than somebody who had an intact nervous system would be able to do. Does that make sense? So usually we say that people with high spinal cord injuries have poikilothermia. And poikilothermia is just a big fancy word that means that the patient's body temperature becomes similar to their environment. Okay, so what that means is if you took this patient with a high spinal cord injury and you stuck them in that refrigerated section at Costco, where they keep all the fresh fruit, and it's really cold in there, Okay? If you left this person in there long enough, their body temperature would drop until it became the same as the temperature in that refrigerated room. On the other hand, if you took that high spinal cord patient and you put them in the sauna and you left them in there long enough, eventually their body temperature would become similar to the temperature in that sauna. Does that make sense? And this is all because the autonomic signals aren't making it past the level of the injury. Something to keep in mind is that a lot of the spinal reflexes are actually autonomic in nature. So while they might still operate below the level of the injury, if they get out of control, the brain is no longer going to be able to correct it. Okay, a great example of that is the vasovagal response. Are you familiar with that? You know, if you stimulate your vagus nerve, do you expect to see sympathetic or parasympathetic effects? Parasympathetic, right? We said that earlier. Okay, so if you do something that stimulates your vagus nerve, like maybe you cough, or you do the Valsalva maneuver, or you change positions really suddenly, or sometimes when we suction our patients, that triggers the vasovagal reflex, okay? And then the heart rate's going to slow, okay? In you or I, if that were to happen, our brains would go, whoa, my heart rate's getting a little too low, I better speed it up, okay? And then we would be fine. But in people with spinal cord injuries, they could actually become really, really bradycardic, because if their heart rate starts to drop too low, their brain might be going, whoa, I better speed that up, but it won't be able to because the nerve transmission has been lost. And so now we have the vasovagal reflex operating out of control. Another example of an autonomic spinal reflex that's operating out of control is a condition that we call autonomic dysreflexia or autonomic hyperreflexia. And I actually like both of those terms because hyperreflexia reminds you that this is a reflex that's out of control, and dysreflexia reminds you that this is bad, right? So this is the way that reflex works. Usually, if there's some kind of stimulus in the abdominal or pelvic region that's uncomfortable, that triggers a spinal reflex that causes your blood vessels to constrict. Okay? Now, if your blood vessels constrict, what happens to your blood pressure? It goes up, right? But in people with intact spinal cords, if the blood pressure gets too high, then the brain's going to go, oh, okay, I need to do something to lower my blood pressure. The brain will send out signals to slow the heart rate. The brain will send out signals to vasodilate. And in people with intact spinal cords, that will keep the blood pressure from getting too high, right? But if you have somebody with a fairly high spinal cord injury, the brain is going to be sending out those signals, but not all those signals are going to be received, right? Usually the heart rate will slow, okay? But only the blood vessels above the injury are going to dilate. The ones below the injury are going to stay constricted. And so the blood pressure probably won't drop, okay? Autonomic dysreflexia usually only happens in people who have an injury above the T6 spinal cord level, okay? At that level, the brain has lost touch with enough of the blood vessels in the body that the blood pressure is not going to get corrected, okay? So in those people with the injury above the T6 level, the brain sends out the message to slow the heart rate, so the heart rate slows. It sends out the message to vasodilate. The vessels above the injury will dilate, and so above the injury, the patient's skin gets really flushed looking. But below the level of the injury, the message never gets received. The blood vessels stay constricted, so the blood pressure doesn't drop. Okay, it stays high. Now the brain's going to go, oh, you know, my blood pressure's still high. I better slow my heart rate even more. I better vasodilate even more. And so as the problem progresses, the heart rate gets slower and slower Above the level of injury, we're going to dilate more. Below the level of the injury, nothing changes. So the blood pressure just keeps getting higher. Do you see? It kind of becomes a vicious cycle. Blood pressure gets higher and higher. The heart rate gets lower and lower. And eventually we're going to run into some problems. As far as symptoms of autonomic dysreflexia, besides the bradycardia and the hypertension, we did mention the flushed skin above the level of the injury. They'll probably be pretty pale below the level of the injury because the vessels down there are still so vasoconstricted. They might complain of headaches because their blood pressure is so high. And they might complain of a stuffy nose because the vessels in their nasal mucosa are all dilated, and so they take up a lot of space and they feel like their nose is all stuffed up. Worst case scenario, if the blood pressure gets too high, what do you think we're worried about? Yeah, if they have an aneurysm in their brain, maybe they could have a hemorrhagic stroke. Or, they could maybe have seizures or other kinds of things that can occur if the blood pressure gets really high. Now, on this slide, you can see some examples of things that can trigger autonomic dysreflexia. We said anything that causes uncomfortable sensations in the abdominal or pelvic region, so that might include a full bladder or, being constipated and having a lot of stool there, tight clothes, pressure sores on their backside. Those are the kinds of things that can trigger autonomic dysreflexia. And so patients whose spinal cord injuries are at T6 or higher, they need to be taught what kinds of things can trigger autonomic dysreflexia, what the symptoms of it are so they can recognize if they're having it, and also talking about what to do if they should develop it. Mostly what we do is we try to identify what triggered the dysreflexia and get rid of that cause if we can. So we're usually going to do a quick check of, is their bladder full? If it is, let's catheterize them. Are they constipated or do they have a fecal impaction? If they do, let's fix that. If they have tight clothes on, let's loosen them. If they have a pressure sore on their backside, interestingly enough, what we do is we put a topical anesthetic on. That seems kind of weird because, this patient would not be able to feel any pain from that. But the painful impulses are still traveling to the spinal cord and triggering that reflex. So if we can put a topical anesthetic on it and prevent those impulses from going to the spinal cord, that should stop the dysreflexia. In the meantime, some quick things we can do is, raise the head of the bed, take off the abdominal binder and the tight support hose, because hopefully that'll get the blood pressure to drop a little at least. And if we can't find a cause, then we will probably have to give them some kind of fast-acting antihypertensive medication to prevent the blood pressure from getting too high until we can, get rid of the stimulus. Oh, and I forgot to say, yes, lots of patient education needed here. Not just the patient, though. Either the family or the person's regular caregiver also needs to be educated, because since this happens mostly in people whose injuries are at the T6 or higher levels, this person is probably going to need some assistance in implementing all of these interventions. And so, yeah, it's important to educate the family and the caregivers as well. As far as intervention for spinal cord injury in general, in the emergency department, usually we're going to first want to realign the vertebral column so we can decompress the cord, and then we need to stabilize it somehow so it doesn't keep continuing to, crush and injure the cord. The stabilization might initially involve some sort of traction, but it will eventually probably involve some kind of surgery so we can have a more permanent stabilization. Surgical stabilization might include bone grafting, which would also require the use of some sort of bracing system to stabilize the surgical site until the bone graft has a chance to heal solid. So if the injury is in the cervical neck region, you might see the patient placed in a halo brace, like you see in this picture. If the injury is lower down on the back, we would probably use more of a torso brace. Sometimes surgical stabilization also involves the use of rods and screws and wires to provide the stabilization to the vertebral column. But we would also need to make sure in those cases that the vertebrae are strong enough to withstand the stress of, having the screws inserted and so forth. We would probably also use corticosteroid therapy, which will help take down some of the inflammation in the spinal cord, and that would hopefully improve blood flow and hopefully to enhance whatever impulse generation is still there. And then we would send the patient to rehab, okay? Because at this point, we don't really know how to restore nerve transmission through that damaged area of the spinal cord. There's lots of research going on with things like stem cell transplants, impulse generators, and other kinds of electronics. But most spinal cord patients don't really have access to those kinds of experimental treatments. And so mostly what we're doing is we're teaching patients how to do as much self-care as they can. We're teaching families and caregivers to provide optimal care and hopefully help, the whole family move towards the best quality of life that they can have. All right. If you have questions, let me know. Otherwise, I will see you in class. Bye.